Hi, my name is V. Bowie, and I'm a PharmD candidate here at Dewville College School of Pharmacy. And today I will be evaluating a journal article entitled "The Effect of Sulfasalazine on Inflammation and Endothelial Function in Patients with Established Coronary Artery Disease." And the reason I chose this article was that the aspect of using a medication typically used for ulcerative colitis for non-FDA approved indication looked promising. The authors are Tabbitt, Holbrook, and Shinuda, among others, and I retrieved this from Vascular Medicine, published in 2012. The primary objective. Before I get going on the primary objective, a little background. Studies have shown that the transcription factor nuclear factor kappa B contributes to endothelial inflammatory activation and reduced nitric oxide production, both events that contribute to the development of atherosclerosis. That being said, the primary objective is to evaluate the efficacy and safety of sulfasalazine, an inhibitor of the nuclear factor, in the treatment of reversing endothelial dysfunction in patients with coronary artery disease. The primary efficacy measure is brachial artery flow mediated dilation, or FMD, which is objective and it's measurable in millimeters, and in this instance it's percent change, and it's well established, has guidelines for uniformity. It is a non-invasive procedure that measures baseline and maximum diameters of the brachial artery to measure endothelial dysfunction. Secondary efficacy measures include systolic and diastolic blood pressures, heart rate, baseline diameter of the brachial artery, dilation to nitroglycerin. This is following 0.4 milligrams sublingually, hyperemic flow, and peripheral arterial tonometry. The study design is prospective, randomized, double-blinded, crossover, superiority, and per protocol. Participants were treated with sulfasalazine or placebo for the first 6 weeks, followed by a 2-week rest period, and then crossed over to the opposite treatment for the last 6 weeks. During the treatment period, participants were treated with 1 capsule of sulfasalazine or placebo twice daily, equaling 1,000 milligrams a day for the first week, and then 2 capsules twice daily, equaling 2,000 milligrams a day for the remaining 5 weeks. 53 participants were qualified and were randomized in the crossover study. 28 participants were treated with sulfasalazine first, 10 withdrew, leaving 18 to be analyzed. 25 participants were treated with placebo first, with 11 withdrawing, leaving 14 to be analyzed. The treatment order was assigned using computer-generated randomization. Baseline characteristics were similar between the 2 treatment groups, as shown here on Table 1. The inclusion criteria included written informed consent, and patients with stable coronary artery disease diagnosed by coronary angiography or a history of myocardial infarction. Exclusion criteria included unstable angina, myocardial infarction within 2 weeks of enrollment, allergy to sulfa-containing drugs, treatment with drugs that may interact with sulfasalazine, including but not limited to Coumadin, digoxin, phenytoin, and probenecid, among others. Patients on immunosuppressive therapy, glucose 6-phosphate dehydrogenase deficiency, and any other active medical illness. The study's length was 14 weeks total. Participants entered a 6-week treatment period, then a 2-week rest period, and then crossed over to the opposite treatment for the last 6 weeks. As for monitoring, vascular function tests were measured at baseline after the first treatment period, after the 2-week rest period, and after the second treatment period. Participants were refrained from smoking and fasted after midnight on the morning of each visit. Participants were instructed to stop taking vasoactive medications 24 hours prior to each visit. Blood was also collected at each visit to evaluate biomarkers such as lipids, glucose, insulin, and systemic markers of inflammation. Analysis of the primary outcome measure, brachial artery FMD, was done on a per-protocol population. The 32 remaining participants that completed all 4 visits provided greater than 90% power with an alpha of 0.05, and that was able to detect a 2% point change in brachial artery FMD. A two-sided p-value of under 0.05 was considered statistically significant. Brachial artery FMD percent change was ratio interval. The statistical test used was two-way repeated ANOVA and was deemed appropriate. Other vascular function variables were also ratio interval, and two-way repeated ANOVA was used as well, and that is also deemed appropriate. As for the results, brachial artery FMD difference between the after sulfasalazine and after placebo conditions was not statistically significant, with a p-value equaling 0.83. Other vascular measures showed no improvement as well, as shown on Table 2. All p-values were greater than 0.05. Tolerability. There was a high withdrawal rate with 21 participants, which is 40%, and it was mostly due to gastrointestinal side effects during treatment. The study results did support the author's conclusions in that treatment with sulfasalazine did not improve endothelial function in patients with coronary artery disease based on measured brachial artery FMD with a p-value of 0.83. At dosages known to affect NF-kappa B levels, sulfasalazine was poorly tolerated, especially in older individuals taking concurrent medications. The strengths include power, set and met, biostatistical test was appropriate, outcome measures were valid and accepted, inclusion and exclusion criteria were adequate, randomization into smaller groups were similar, length of study was appropriate, dosing was appropriate for safety and efficacy, the blinding was sufficient, and the conclusion was supported by the results. As for the limitations, there was the high rate of withdrawal, however, power was still met. There was also concurrent usage of medications that may have modulated the effects of sulfasalazine. The serum levels of sulfasalazine and its metabolites were not measured to confirm patient adherence. Dosage was based on studies in rheumatoid arthritis, which demonstrated an effect on circulating cells. The effective dose may be higher to affect the actual endothelium, but it would have limited clinical utility due to increased intolerability. The level of evidence is 1 with minor limitations, as mentioned above. As for the recommendation, I recommend that patients with coronary artery disease should not be treated with sulfasalazine to improve endothelial function for the following reasons. In efficacy, this randomized double-blinded placebo-controlled level 1 trial with no major limitations demonstrated that sulfasalazine had no therapeutic effect on brachial artery FMD with a p-value of 0.83 or other vascular functions, all p-value being greater than 0.05. In safety, the dosage, which was 1,000 milligrams a day for the first week and 2,000 milligrams a day for the next 5 weeks, was based on previous studies on rheumatoid arthritis and its inflammatory processes. This dosage was not well tolerated due to the adverse gastrointestinal effects and contributed to the high dropout rate of 40%. Cost was retrieved from Micromedics 2.0 Red Book online. I found that sulfasalazine 500 milligram oral tablet was about 22 cents per tablet. And just for comparison's sake, I took aspirin 81 milligrams oral tablet, and that was about 2 cents a tablet. The higher cost and lack of efficacy of sulfasalazine on preventing future myocardial infarctions are not as appealing as, say, low-dose daily aspirin, a commonly used antiplatelet to help prevent clots, and which is among other typical cardiac health medications that have been well documented as well. As for special considerations, sulfasalazine is FDA approved for rheumatoid arthritis up to 3,000 milligrams a day. A study to include patients with severe rheumatoid arthritis with concurrent coronary artery disease treated with high dosage sulfasalazine should be considered to show any effects on endothelium. Another thing is that the study included participants in a more advanced phase of coronary artery disease. It is a possibility that the endothelial dysfunction may be more resistant to sulfasalazine's inhibition to NF-kappa B activation. Also, patient lipid profiles were well controlled with previously established concurrent treatment. These two factors may have masked the clinical efficacy of sulfasalazine. Perhaps a more prophylaxis-based study should be considered. And thus concludes my evaluation of this journal article. Please email me at buiv10@dyc.edu for any questions and comments. Thank you.